Good evening. We're live now. Good evening. I'm Dr. Brian Gallagher, and I just wanted to take some time out of my evening to talk to you about a topic that is strangely near and dear to my heart. But that's about bunions, and particularly minimally invasive bunion correction, which is a new way we've been doing bunion correction for the last several years, which I think has really revolutionized and really brought the field around to a really common problem and things that we see really frequently here in the clinic. So first things first, I just wanted to talk a little bit about myself. Here's me. I grew up outside of Philadelphia and a big Eagles fan. I know that can be tough in this area. When I was younger, I played football and rugby, and I think kind of being in that whole world is what got me into the orthopedic world in particular. What brought me back to the area is I went to undergrad at Georgetown, so I'm a big Hoyas fan. In medical school, I was back in Philadelphia at Jefferson Medical College, and I did my residency and fellowship at Union Memorial Hospital, which is associated with MedStar in Baltimore. So I basically lived my entire life up and down I-95. And then there's, what do I like to do in my spare time? What do I enjoy? I have two young boys right now. One's 4 years old and the other's 1 year old. So they tend to keep me pretty busy. And I'm already bringing in the next generation of Philadelphia fans with our burgeoning Eagles and Philly fan over here. My youngest, a little too young for that, but he'll come around. And then most importantly, what do I do? I myself, I do almost exclusively foot and ankle orthopedics. And foot and ankle orthopedics is kind of a broad swath of orthopedics, kind of localized to one particular body part. And that really encompasses a large amount of orthopedics. I do a lot of trauma, fractures, ankle fractures, tendon ruptures, Achilles tendon ruptures, reconstruction and deformity. So really common is flat foot deformity, low arches, high arches. Some more advanced congenital deformity. We do sports type injuries with ankle arthroscopy, ankle instability, ankle sprains, and the type of injuries that you get by being an active person involved in sports. We do ankle replacement and revision ankle replacement, which is, while not as widespread and as common as hip and knee replacement, it's still quite quite an excellent field and quite an excellent surgery we do for quality of life. We do arthritis of all kinds, and most importantly today, what we're going to talk about is bunions, and in this particular talk, minimally invasive bunions. So I kind of like to lay out some educational objectives just to kind of frame what I want to talk about. First, I want to talk about what a bunion really is. There's a trouble where it's one of those colloquial terms that people throw around and can sometimes lead to a little bit of confusion. And then I'd like to talk about the sort of nature versus nurture in the world of bunions and why they form. And more important, I'm going to touch on the concept of rotation. So just kind of keep that word in mind later. We'll kind of touch on first line treatment and kind of what you can do at home before you have to see one of us. I'll then go through sort of historical approaches, and some of it's going to be a little bit of a slight, trip through time on where we were and how we got to how we approach these things now. And then I'll kind of transition that to introducing what we call the fourth generation minimally invasive bunionectomy. And then sort of on the back end, I do want to talk about, what we do end up with a lot of surgery and then the recovery process. So the question is, why bunions? Why are we here tonight? What gets us so interested in bunions? And at the end of the day, it's because bunions are really common, but they can cause a lot of pain and they can really hurt. They can, cause people to limit your activities, make it tough to do the things you want to do. One of the major complaints I get is you really can't fit into the shoes that you want them to fit into anymore because it's so painful. And as a result, people have to limit their activities. In some of their extreme forms, bunions can be quite severe and actually cause quite severe deformity. So the answer is because they matter and because they impact, a large people's quality of life. The next thing I want to talk about is what is a bunion. Again, this is one of those colloquial terms that gets thrown around. And I just kind of want to demystify a little bit of that and make sure that we're all on the same page and talking about the same entities, because there's a lot of different things that can cause pain in the forefoot that might not necessarily represent a bunion. So, on the left side of the screen here is, what a classic bunion is. It's this medial prominence. It's based on an abnormal angulation. And on this x-ray, you can see how that big toe is kind of deviating out, deviating inwards towards the lesser toes. And kind of back on this one, you can see where it's really a matter of angles that causes a prominence. And that prominence can become painful because of where it is in shoe wear. The middle screen is arthritis. just like everywhere else in the body, that big toe joint can become extraordinarily arthritic. And even with arthritis, you can actually have some eccentric wear and almost mimic the angulation of a bunion. But in reality, it's just good old-fashioned arthritis, which if you've been a member of the Anderson Clinic for too long, you probably are quite familiar with. That's associated with generalized bony overgrowth, bone and bone contact, and pain with activity and pain related to that. And then there's something called a bunionette, which sounds smaller and less severe, but what that is, it's sort of a similar process on the outside of the foot, and causes pain on the outside of the foot in a similar fashion. But that's a bit out of the scope, and we can talk. But that's something we can talk about at another time. This is another thing. This is incredibly common. Patient comes into the doctor's office complaining of pain in the big toe. It must be a bunion, and this is kind of the distinction of bunion versus arthritis. So on the left side of the screen, at the big toe, you can see where some of that, you can see there's cartilage loss, there's bone on bone contact. On the bottom one, you can see there's this big whale, the shark fin at the big toe joint, and that's arthritis. It's wearing away of the cartilage. Compare that to the side on the right side of the screen, where there is no arthritis. It's more of an angulation, a malangulation, and a bump on the outside. It's interesting how these two have so much overlap in their presentation, but we manage them so differently. Then again, we'll take this even to a smaller level, some other lumps and bumps that I've had people say, hey, I'm here for my bunion, and it's something called, it's either a plantar wart, a plantar corn. Corns are incredibly common. What they are is it's a hyperkeratotic. It's a big extra callus under areas of high pressure. A lot of times you see it on the bottom of your foot. So corns are a callus and bunions are a painful prominence. So hopefully this kind of it gets us all on the same page in terms of our vocabulary about all of it. So then this kind of begs the question, so why bunions? I'll kind of go back and say, why do these happen? Why do these things form? Is there a congenital aspect of it? Is there an acquired aspect of it? And the big question is always, is there nature versus nurture, congenital versus acquired, genetic, and any genetic predisposition? So if we look back and you can look at the large populations of the world, and it's really interesting when you compare we call it the shoe-wearing population of the world compared to the population of the world that doesn't wear shoes. And if you look at the comparison between the two, there is a much, much smaller incidence of bunion formation in the shoe-wearing population of the world, which tells us that there is a bit of a nurture aspect, an acquired aspect of these things, though that number is not zero. So there is, and you do often see the complaint that, hey, bunions run in my family. My mother had them, my grandmother had them, I have them at a young age, which tells us there's likely a congenital aspect to certain bunions. So the long and short, just like everything else, is there's a little bit of nature and a little bit of nurture. But as we found, there is a large environmental factor, and a lot of that does involve shoe wear. And some of this, and that, as to my last bullet point, it comes down to a little bit of sociology that, the types of shoes that society has us wear has some bit of an implication in the bunion formation and the bunion deformity. At the end of the day, we're going to talk about this concept again. Why bunions? Why did this happen? And it comes down to a concept of angles and instability, but most importantly, rotation. If we look at the X-ray on the bottom, you can see all of these angles are drawn out, and really this is what bunions are at the end of the day. It's a question of angles. The first metatarsal ends up deviating a little bit inwards and deviates away from the second metatarsal, and that's where he says IMA is the big angle there. We call that the intermetatarsal angle, which is the angle between the first metatarsal and the second metatarsal. Usually they're relatively collinear, but as a bunion deformity starts to progress, these angles start to spread across. And then what happens as a result, instead of the big toe pointing off along with it, the big toe tends to fall back into the space, and that angulation, this HVA is the letter that is the angle that's put there. That hallux valgus angle is the measure of how much of a deformity and how much of a bump there is. And we can measure these angles and we can grade these angles as mild to moderate severe, but this is where all these are coming from. This is unfortunately, we're always a little bit limited by our two-dimensional views of this from two-dimensional X-rays. But in reality, this is a three-dimensional deformity, and that middle picture shows this concept of rotation. That as that big toe starts to deviate out inwards, it also tends to rotate with it as well. And we'll get to a slide to kind of show this a little bit more granularly. But that rotation also causes some deviation inwards. So part and parcel to this, this deviation inwards is this rotation, and the rotation is the issue that we've been dealing with for so many years as a challenge to correction of our bunions. And again, we'll get back to why this fourth generation is so important. So that's in a nutshell why bunions happen, where they happen, mechanistically, what drives their creation. What's important to know is how can you start to deal with this yourself? And we talk about over-the-counter management, or what I kind of call the Amazon shopping cart approach. There are pads and spacers, toe separators, toe pads, silicone sleeves, and what have you, that can really occupy space in the shoe, separate the toes, and give symptomatic management to help offload that painful inside of your foot. Part and parcel with it goes wide toe box shoes. Really, we're just accommodating to this deformity rather than correcting it. There are, what we call bunion correctors that you can go on Amazon. I found this one. You can pay $60 out of pocket. That's this almost medieval machine that holds your toe and puts it out in space and promises that it's going to hold there. Unfortunately, those over-the-counter correctors are not able to permanently or meaningfully alter your own anatomy. They'll only really temporarily hold that there, and the second you take the thing off, it's going to spring back into place. The part that I liked about this the best is that you can still go on Amazon and see that it has 4.5 stars. So I don't know who's reviewing these things, but unfortunately, I can't stand by using them. So the question that comes after we've done the Amazon shopping cart approach, we've tried all the pads and the spacers under the sun, even bit the bullet on the bunion corrector. Now, is when is it time to do something about it? And it's always the question: when is it time? And the time to come in to see us, the time to approach and try to increase the amount of increase your intervention on this is at the end of the day based on pain and function. And when you start to notice that that pain on the inside at that bump is starting to get worse, if you're the type of person who's suddenly having to throw out all their fancy nice shoes that they used to love to wear, or even sometimes when these deformities progress so severely that you start to have these crossing over toes or deformities that are starting to get out of control. And that kind of comes to the second point. You can see this picture and see, and wonder or not if that's going to be you someday. The question is, why do I have this crooked second toe? And the reality is because the big toe is a bully. We play this game of angles. It's almost like you almost feel like you're lost in high school trigonometry again. I'll try to use the picture on the right, and again use this concept of deviating out to the side. If you look at that blue line on the end, that's sort of that would be the normal anatomy. And then imagine that big toe starts to deviate out. Let that big toe start to fall in. Just like your high school math teacher would say, that your relative length of your first metatarsal in relation to your second metatarsal, it starts to shorten almost because it's the hypotenuse of that triangle is starting to deviate out. As a result, your second metatarsal head starts to see a little bit more stress. Over time, sorry, this is kind of getting in the way. Over time, if you look at this metatarsal head from the side, it can cause some attenuation of one of the structures on the bottom of that joint. And that's going to cause your second toe to deviate up and the flexor toe is going to pull it down. But that's where this hammer toe comes in. Over time, this deformity can progress. And once that big toe starts to pop underneath that second toe or other way around, it's kind of off to the races. The big toe has really just bullied the second toe out of the way. So it's really interesting how this deformity over time left unchecked can progress and start to really snowball and cascade through the rest of the foot. And they're really at points where these things can really become quite severe. Now I want to kind of talk on historical perspectives, kind of where have we been, where are we going? I tell people there are three real classic ways to manage a bunion. Well, I'll backtrack. There have been over 100 different ways to do a bunion surgery, but they generally fall into 3 big buckets. One that I'm not going to talk about is doing a big toe fusion when there's arthritis of the big toe. Again, we kind of touched back there as there's arthritis as its own separate thing. But there's the classic, what we call distal chevron. It was this big open incision on the inside of the foot to shift the big toe first metatarsal in. Then there is this more historical procedure called a scarf, which is cutting the bone farther back. And then finally, there's something we still do today for large deformities called a lapidus fusion. For most bunions, we were doing this thing called distal chevron. It allowed for mild to moderate correction, but it required an incision that could cause a lot of scar-related pain. That's kind of an important part of the foot. That's the inside border of your foot that often makes contact with the inside of your shoes. And it ended up causing a lot of scar pain, especially in tighter shoes. This thing called the scarf osteotomy, while a little bit more historic, we were able to get stronger translation, but it was not able to correct this, again, back to this concept of rotation or instability. And then we got to this, and then we have this technique called lapidus fusion. It's the most powerful way to correct a bunion. It allows for correction in all 3 planes, but unfortunately, it does have the highest rate of complications in non-union, and it also causes some shortening of that column. So while it's an important correction, and for the right patient, absolutely the right surgery to do, for the vast majority of people, we're kind of moving forward towards this minimally invasive correction. And the reason that it's becoming the gold standard these days is because it allows for early weight bearing. There's a lower complication risk, less scar pain, and with our newest techniques, we can get a correction in all 3 planes. And again, that most important concept of correcting rotation. And this is, I've said that the word rotation over and over again. And this is a slide I kind of want to kind of show it to you how this all happens. And I'll kind of go from left to right to try to stay with me on this one. Rotation is really the key when we're talking about bunions. So on the left, you can see this red arrow. Bunions often form because of instability of that joint at the base of the first metatarsal, near where that red arrow is. Imagine that starts to rotate outwards, and sometimes in even severe ones, you can see that big toe is actually a little bit rotated. In this neutral position on the left side, I call it the normal side, that big toe joint is moving in plane right here. It's moving up and down. And if you look closer in these sort of straight lines right here, you see this first metatarsal sort of is square in a square alignment. As we look to the second from the left, as you see that first metatarsal begins to deviate its way out to the side, that metatarsal begins to rotate. Suddenly, the flexion extension is out of plane of our X-ray. It's not exactly in the same plane. So that malrotation is allowing that toe to flex a little bit out of plane, which can sometimes lead to further progression of the deformity over time. And that's what's important here is, and this one, this post-op one to the right, as you can see, that we're able to shift in and actually correct some rotation to help correct the driver of what's getting this, of this deformity in the first place. And really, that's what's important now, and what's brought us to this 4th generation minimally invasive bunionectomy, which is to say we've been doing some minimally invasive. We've done a minimally invasive bunionectomy before, and over time we've been able to progress this to a point where we can do it from a minimally invasive approach in a real, reliable, reproducible way with implants that match the technique. And we always say, what is a generation? What makes the 4th generation different? And that is the concept, and that is the ability to do this from a percutaneous is the word, but small poke hole approach. You can see this kind of going from left to right now. We're able to outline the metatarsal and utilizing this small burr. It's what it is. It's a burr. Make a small poke hole, and we're able to actually make a cut in the first metatarsal, sweeping up and down through this small poke hole again to gain correction. What makes it the 4th generation now is we have tools that are able to do it in a more reliable, more predictable, more reproducible way. Jig systems with integrated wires that allow us to correct this and place the fixation across. Specialized implants that are designed that have special beveled edges and that can fit in and cause less hardware prominence. more specialized and a greater diversity of our cutting tools, our burrs, which is sort of the engine that lets us cut and correct the deformity that we have. So that's when I go back to what makes the fourth generation different. I compare this up top right here. The drawing is what we call the historic distal chevron, where you actually made this chevron cut in the metatarsal head and shifted over. While it's an incredibly secure and stable bone cut, you can imagine there's no way to correct rotation through that because it's triangular. The fourth generation is a transverse bone cut. It's just a bone cut right up and down. And since it's a bone cut right up and down, you're able to rotate the metatarsal head and correct the rotation after you've performed your correction. So here's what it looks like, where you see this transverse bone cut with these two long screws that can fit, and these are two different, not the same one, two long screws that fit in and secure that metatarsal head fragment. You'd see that into the toe itself, you see a third bone cut screw that allows us a little added correction after the fact to be able to really dial in the appropriate correction of the bunion. So then the question, okay, it's fantastic that we're able to do this from a minimally invasive approach, but why does it really matter? And most importantly, it's that in our experience, it's a faster recovery. The smaller incisions mean there's less incision, typically not always, less swelling, and most often less pain. To go with all of that, there's less stiffness. It allows us earlier physical therapy because there's less incision, and a lower wound complication rate because there are so fewer wounds. Going with that is there's better cosmesis because there's not a scar on the inside, and we've actually gotten a documented quicker return to work and a more minimal opioid usage compared to the historical ways of doing it. We talk about the severity of bunions, but the minimally invasive approach is small. It's minimally invasive, but it is quite mighty. And even for more moderate deformities, we can still successfully get a good correction of the bunion deformity. In terms of the faster recovery, that's what everybody wants to know. And what is a post-operative recovery looks like. And the nice thing is weight bearing on your heel in a post-operative shoe or a boot right away. Seldom is there a need for any protracted time of staying off your foot. I usually like to tell people, while it's ambitious, if you want to walk out of the surgery center, I'm okay with it. We usually keep you in a post-operative bunion dressing for about 2 weeks until we see you back in the office. And most people are out of that boot or shoe in favor of your own shoes by around the 4-week mark. Physical therapy starts at 4 weeks, and it's really geared at early range of motion to work out that stiffness, work out that swelling, and get motion returning into the joint. Typically, there's no running or impact activities for a total of 3 months and no high heels for 3 months for those who enjoy that. Here's just a glimpse of what post-operative medications look like. Most people get by pretty well with extra strength Tylenol and once-a-day anti-inflammatory called Celebrex, and only the smallest amount of oxycodone, which is the narcotic pain medicine. Beyond that, I do vitamin C and vitamin D for bone and wound healing. And as we said before, even though it looks a little jarring to see that metatarsal head fragment shift all the way over, the question is, the reality is, don't fear the shift, because you can gain excellent correction, because oftentimes the results do speak for themselves. So I'll kind of draw back to where we all started to understand what a bunion really is. A bunion is a progressive deformity of the forefoot, where there's an abnormal splay between the first and second metatarsal that allows the toe to drift in. It's a pain along the medial eminence, is what we call it, the inside of the foot, and this would be as opposed to arthritis. We've kind of touched on nature versus nurture in the world of bunions. There's a component of both. There's a congenital component of some aspect of it running in the family, but a large component of nature and what we do impacting that bunion's progression. Unfortunately, it is a lot of time the shoes and the activity in the shoes we choose to do. We kind of touched on the first line of treatment, sort of that the over-the-counter pads, spacers, and accommodative shoe wear. And we touched on some historical approaches and how what we've done through the years has driven us to come up with a better way of doing it. And that's brought on to the 4th generation minimally invasive bunion correction, which is a way to correct it through small poke holes, and more importantly, be able to correct that concept of rotation. And then, we touched on surgery, how we do it, why we do it, and how the recovery process is really getting much easier now than it was before. So I wanted to say, for those of you who are on with us, I really wanted to say thank you. And I open that up to people out there who have any questions. So the first one I got is, what are the potential risks and side effects of a minimally invasive bunion surgery? And ultimately, they're the same risk. They're the same risks of any bunion surgery. So the risk of infection, thankfully, hovers somewhere in the neighborhood of 1%, and we tend to have especially better superficial outcomes because our incisions are so much smaller. There's always a risk of the bones the shift in the bones not healing. We found that historically was a problem because people weren't using proper technique. These days, we've learned that through the use of proper irrigation, shield irrigation, and really temperature management while you're doing that burr cut, that can really, really limit that outcome. And there's with any bunion surgery, there's the risk of recurrence. It's a really interesting question that we could talk on for another half hour. But what the minimally invasive bunion correction does is it restores that normal axis of the big toe. It does not correct some instability in the big toe, so there's a theoretical risk of recurrence. But oftentimes, by rebalancing the metatarsal head into the correct axis, it can really reduce the risk of recurrence. But yes, that is still a potential side effect. How much pain should I expect after the next question? How much pain should I expect after surgery, and will it be managed? The answer is, thankfully, compared to the historical open approach, most people are getting along pretty well with oftentimes just Tylenol and anti-inflammatories. Occasionally, some people will need a little bit of narcotics to get through it. But yes, typically that's the way we manage it. And the third question I got is, are there any alternative treatments that you can consider before surgery? And that's kind of what we touched on in terms of, finding ways to accommodate for the bunion being present. So modifying your shoes to not be so constrictive, using the pads, spacers, toe separators, what have you. Well, there's no good non-surgical way to correct the deformity, correct the anatomy, if there's ways we can, try to mitigate its impact on our day-to-day life. I'll never forget, I've had a couple patients actually come into the point where they've cut the sides of their shoes, let the bunion hang out the sides of their shoes, to try to avoid having to do anything. And honestly, as long as people are managing whatever way that they can find a way to fit it into their life, as long as you're able to do what you want to do and function at a high level, the bunion can fit into your life however that is. Mm-hmm. That is all the questions I've got for you today. Again, I'm Dr. Gallagher at the Anderson Clinic. I see patients at the Reston office, Fairfax office, and Shirlington office, exclusively foot and ankle orthopedics. But I'm happy to see any of you guys anytime and talk more about bunions anytime. I appreciate for guys who are taking the time to watch this tonight. I appreciate all you guys who are taking your time to watch this another time.